surgery. When this topic came along, it was suggested by especially Joel Cooper, but many others, that we should select patients only who have clearly destroyed lung tissue, which is functionless, and for sound reason it is easy to understand that this patient may profit the most. But if you think again on this, on the connection between function, symptoms, quality of life in patients with COPD, then it's easy to understand that patients who are severely hyperinflated with a high residual volume, high total lung capacity, that these patients have a severe problem with the chest wall mechanics. And this chest wall mechanics is a key factor for patients to develop dyspnea. But furthermore, this has also an influence on the heart and also on the whole circulation. And therefore, we hypothesized that when you select patients with homogeneously destroyed lung tissue properly, that by improving this chest wall mechanics, that these patients may profit as well. So let's go quickly back for those who are not so familiar with the pathophysiology which is behind. This is the lateral view of a patient with emphysema, flat diaphragm, highly overdistended chest. If you resect the part of the lung tissue, you see two effects, and I think we have heard this already. You have an improvement in the airflow because the pull-out forces on the small airways are restored, the theory from Brentigan, and the other effect is that you change this highly highly overdistended chest into a normal-sized chest, and the diaphragm, which is flattened and cannot move up and downwards anymore, moves upwards and works again as the most important muscle for respiratory mechanics. So our hypothesis, independent of the quality of this tissue, if the remaining lung tissue is still good enough for sufficient gas exchange, you will have a positive effect as well. When you look at the patient with emphysema, you look at him and you see the typical clinical signs. You measure airflow, the FV1. You measure plethysmography, the volumes, the residual volumes, total lung capacity. You can measure gas exchange. And at the end, you have your patient characterized. What we usually don't do, and especially the pulmonologists don't do, they never look at the quality of the lung parenchyma. I used here the perfusion scan, and in the upper panel use a patient with homogeneously perfused lung, which means that the destruction is the same from top to the bottom, and in comparison a perfusion scan where the upper lobe is completely destroyed. So it is extremely important when you go into emphysema surgery that you look at the emphysema morphology. And there are different ways. If you are experienced, you can analyze the CT scan, and you find out the ones which have a completely uniform destruction, or those who have a more severely destroyed area on a certain part. You can also use a software which indicates you areas, like in this case in the upper lobe, or in this case more in the upper lobe, in the lower lobe, showing where the most destroyed areas are. There are different propositions how you want to classify emphysema morphology in relation to lung volume reduction surgery. On the very beginning, we used a simplified system. And when you analyze the CT scan, you have to decide if the destruction is the same from the top to the bottom, which we call homogeneous. And it's also easy to recognize those which have a significant area of complete destruction, which is called markedly heterogeneous. So when you have these two groups, you have a remaining group which we called intermediately heterogeneous destruction. You find some areas, but usually these of more destroyed lung tissue, but usually these areas are less prominent. So we are focusing on this group, which is called in the net as the non-heterogeneous non-upper lobe emphysema. So we were concentrating on this, and I will show you the data in a while. When you looked in the on different single-center studies, most of them, like Joel Cooper's group, upper lobes, some of them don't really go into the morphology, upper lobe, but Brenner basically also, when you talk to him, they used upper lobe emphysema. And we were more or less the only group who included all morphologists, at least in a larger number. We heard already about the NET trial in detail, and the NET trial assessed all types of severe emphysema. But especially they looked at the upper lobe predominant emphysema, and when they defined the selection criteria, they did something completely different than all the other single studies did before. I used our selection criteria, but all the other single-center studies which were published before by Joel Cooper's group, Doug Wood, whoever you take in Europe, David Waller, we all excluded patients not only with pulmonary hypertension, but also those who had a completely destroyed lung. And the best way how to assess a completely destroyed lung is CO diffusion capacity. Hypercarbia may also be helpful, but CO diffusion capacity. And the NET did not use these criteria at all. So, not surprisingly, they ended up with this publication in the New England Journal of Medicine. And patients at high risk of death after lung volume reduction surgery. So what did they do? They included patients with homogeneously destroyed lung and additionally a low CO diffusion capacity. So if you have not enough lung tissue for gas exchange and you undertake them to surgery, it's not a surprise that these patients have a high risk to die. And we heard already from Doug Wood, and this publication was the most important factor why lung volume reduction surgery got this bad press. The majority of physicians, they thought all patients who undergo lung volume reduction surgery are at high risk because they didn't really read the details and didn't understand the differences. And furthermore, many surgeons thought homogeneous distribution means high mortality, which is not the case. We saw this data already from Joel. So I want to show you now the patients we have studied in Zurich, 250 patients in the years until about 2 years ago. And in the CT scan, 138 had homogeneous disease, either completely homogeneous or an intermediate type, and the other ones were 112 had heterogeneous emphysema. And I'm talking now about on this group. Patients, the mean FEV1 was 28%, These were the age distribution, and I compare it with the heterogeneous group. 58 upper lobe, 54 lower lobe. So I compare this group now with the homogeneous, and this is the data we have observed in Zurich. The effect on dyspnea, on the medical research count, both groups started more or less on the same level. The heterogeneous group had a slightly more impressive improvement, but the difference between the groups were statistically not significant. And the patients, these well-selected patients with homogeneous disease, had a good outcome, which lasted also for 4 years, statistically better than the starting point. Pretty much the same was seen in the 6-minute walk test, started at the same baseline. More impressive improvement in the heterogeneous group, but a significant and long-lasting effect in the non-heterogeneous group. And if you look at the FV1, the same, almost 75% improvement in FV1 in the heterogeneous, but the homogeneous also close to 40%, and it lasted over a longer period of time. What has been observed by others was also seen in our group. The long-term survival in the patients with the non-heterogeneous group was less good than in the patients with heterogeneous group, and at 6 months there was a statistical significance in these patients. And the difference was not seen so much in the early period, it was more seen after 6 months. So these patients have a less good prognosis in terms of survival. So based from our experience, and unfortunately I cannot show you other data from the literature because I just couldn't find large patient data from other groups in this subset of patients, we concluded that benefit of LVRS may last for up to 4 years in all morphological types. And a significant profit was seen in non-heterogeneous patients with a MRC dyspnea score improvement up to 48 months and FV1 up to 24 months. Slightly inferior, but from a clinical standpoint for the patient also a good benefit. However, long-term mortality differs compared to the heterogeneous type, but this has most likely nothing to do with surgery rather than with the disease itself. So, how shall we select patients in the future? The good ones are the ones symptomatic, marked hyperinflation, marked heterogeneity. We have heard this very clearly from Joel Cooper, upper lobe disease. The bad patients, and these patients you should not touch, CO diffusion capacity below 20% or FV1 below 20% and homogeneous disease. And then there is an uncertain group, and among those you can select patients which profit as well from LVRS. They must be marked hyperinflated. They don't need to have a clear heterogeneity, but the CO diffusion capacity, and this is very important, must be above 20%. Thank you very much.
Thank you very much, Walter. Maybe you can stay, and we have a few minutes for discussion, not only for Walter's trial, but for everybody, all the speakers too. So are there questions from the floor? Yes, please.
Anu Sioris from Finland. Just want to ask which side...
Is the microphone on?
How do you select the side where to begin when you do a two-stage procedure?
normally go for the right side, and assuming that the perfusion is sufficient on the left side to allow single lung ventilation. So if the bilateral target areas and a 50-50 split, it's never that 50-50, but we would always do the right lung because it's bigger.
Do you tell the patient that, as when I understood correctly, when you do the second time on the left side, the results or the improvement is less big than when you do it on the right side the first time? Is that correct?
We haven't studied in comparison. It's the overall benefit. So we tell the patients that they have the chance of having we talk about a curve that they're descending down a curve of disability, and we can push them back up the curve by operating on one lung. They'll slide down again, and then 4 or 5 years later we'll push them back up again. And that's what appears to have happened, is we've spread out the overall benefit by staging the operation.
But is the second push-up as good as the first one, in your experience?
From those graphs, yes, there was significant benefit. So they had a significant improvement over baseline in their pulmonary physiology. They never lost the volume reduction effect, so they always had smaller lungs than when they started, but their FEV1 declined and then was pushed back up again, and their health status, which is difficult to compare, their health status remained above baseline for the whole period.
Because the mediastinal shift, when you do it unilateral, the second time might be less pronounced, you know. When you do it unilateral, you also have a mediastinal shift on the operated side, and when you do it the second time, this effect might be less pronounced. So,
yes, so their volumes do increase. What we've never done is operate on the same side twice, although I have seen case reports, I think, of that being done. Theoretically, I suppose you could go back and reoperate on the lung you've already operated on, which would give another potential group of patients benefit who are only suitable for unilateral surgery. We haven't encountered that yet.
Maybe discuss the same topic.
May I ask a question, please? I'd like to ask about a technical question. When I was in training, I observed both types of techniques, open and videoscopic, and participated in some. And sometimes I wasn't that impressed with the videoscopic approach. I felt that there was over-manipulation of the lung. Now that I have my own practice, I do more and more videoscopically. And I would like to ask the panel what they think is the best approach videoscopically. And what I mean by that is, do you think that it's best done in an approach similar to a VATS lobectomy with a small utility incision? Do you think there's a role for a uniportal technique, which I know that Cliff has some experience of? How is the best way of doing this videoscopically to minimize morbidity? That's my question.
Maybe, Walter, you can answer something to this.
I think it's important that you feel familiar with, that you feel comfortable with the technique you apply. For us, we do a videothoracoscopic approach in all cases except those who have significant adhesions. Then we go over to a thoracotomy. But the majority, we do 3-port incisions, and we do it thoracoscopically. The most important thing is, before surgery, analyze the CT scan. You must have a plan in your head how and what you want to resect. If you do an upper lobe hockey-shaped resection, this is extremely easy to do thoracoscopically. Transfer this into surgery. When you use certain landmarks, David quickly mentioned the azygous vein. The azygous vein is important to use as a landmark to get an idea how much volume you want to resect. So my preferred approach is always thoracoscopic approach. I use 3 ports, one for the camera, one for the forceps, and the other one for the staple.
Just 2 technical tips. The first thing, when the anaesthetist puts the double lumen tube in, they have a tendency, it'll be the junior anaesthetist, to connect the patient to the ventilator on both lungs, so that both lungs get positive pressure ventilation. And that makes VATS very difficult. When you try to go in then, the lung is hyperinflated. It may not be ventilating, but it's air trapping. So what I would suggest that you do is actually stay in the anaesthetic room when they're putting the double lumen tube in, and make sure they don't ventilate the operating side. So have them put the double lumen tube in, but not connect it to the ventilator on the lung you're going to operate on, because it prevents the air trapping. If you do have air trapping when you get in with the thoracoscope, don't hesitate to take the diathermy scissors and cut the lung. On the periphery, you know you're going to take that part of the lung out, go in and incise the lung and deflate it. And it's amazing how much deflation you can get by simply incising the lung on several places on the periphery of the lobe, and then you're going to take it out anyway, so you're going to take out the part with the holes in. But that's technically the most difficulty I find, is of the air trapping, trying to guess where you're going to put your staples with the lung inflated.
Do you use utility incisions?
No.
Excuse me,
Do you use utility incisions to take the pieces of lung out, or is it really with very small ports, 1 to 2 centimeters?
If it's deflated, it's small, so it's just.
Thank you very much.
Joel, you wanted to comment, I think, on the bilateral or unilateral.
Yes, two things. First of all, I gave the elementary talk, and Walter, you gave the postgraduate talk. We all have to agree selection is very important. There's some general principles. I completely agree with you. There are exceptions, and knowing those exceptions is extremely important, and I don't disagree with you whatsoever. The problem in the NET trial was they changed the rules twice in the middle of the trial, but they did, as you pointed out, homogeneous, low FEV1, low DLCO, and that's what led to a 30% mortality at 6 months. David, I had a question for you. I understood your presentation in terms of one side versus staged, but I wasn't sure where was the data that you used to suggest that a bilateral procedure versus a unilateral or staged unilateral, that they were equivalent, because I saw you had for your unilateral 4.7% mortality at 30 days. Our 90-day and the NET's 90-day in similar groups was 5% at 90 days. So I am not sure I saw the data which convinced me that compared to a bilateral procedure, either a unilateral with or without subsequent staging was a superior approach.
So it's not superior in terms of lower risk, it's equivalent. So it's no higher risk, because the idea is that you give them 2 operations and double the risk. So that doesn't occur. The difference is that you spread the benefit out, and we've not found a longitudinal benefit in physiology, but particularly in health status. And we've got these patients under captive follow-up, as I've said, for up to 5 to 6 years. Their health status has deteriorated, the 2-stage, the 1 operation, 2 lung operation. What we found is that by spreading out the benefits of the operation, we can maintain their health status, which is really what concerns us, not the physiology so much. We've able to give that second wind benefit that means that 6 years, those patients who've had 2 operations have got a health status benefit. Those patients that had the 1 operation 6 years previously have lost their health status benefit. So what do you do for those patients? You think of reoperating or transplantation or endobronchial valves.
So once again, for an equivalent group of patients,
these are equivalent.
6 years,
yes.
Whether they had a single procedure, both sides done, that was not as good for an equivalent group of patients who had started off with.
That's right. They were all suitable. They all had bilateral target areas, and that was including, that's on an intention to treat basis, which Doug's pointed out at a previous presentation, including those patients who have yet to have their second operation. If you include all of those people, they've still got prolongation of the health status benefit. And these people are walking around after 1 operation. They haven't requested to have their other operation yet. They know they can at any time, but they're still happy with their health status. So we're guided by them.
Also psychological effect.
Just one. David, maybe I have not understood or seen the data correctly, but in the bilateral group, the FV1 lasted only for the improvement of FV1 only for 6 months. Is this correct?
A year.
6 months or a year. Because in most other series, including the NET, the bilateral group goes up to 2 to 4, even to 5 years, I think, in the other group. So maybe this relatively small number of patients who were treated bilaterally were not very good candidates that the FV1 improvement lasted only for such a short time.
It's possible, but because they are small numbers, but they still had volume reduction in that their volumes, it wasn't as though we weren't taking enough lung, because they had significant reduction. They had the same selection criteria, they had the evidence of volume reduction, and yes, they're FEV1. I don't actually think FEV1 is a very good measure, because you can, when you've got a small, particularly if you look at percentage change, I mean, we all know they've got some element of reversibility, these patients. So I'm not really hung up on FEV1. We've got patients whose FEV1 has gone down. They still feel a lot better from their operation. So I'm moving away from using FEV1 as an outcome measure. I'm more interested in how their health status, their perception of what their daily living activities entail.
Thanks. We have time for one short question before the coffee break.
A technical one. Post-operative air leaks can be quite a problem, and also late onset spontaneous pneumothorax in these patients. Would you think it's a good or a bad idea to take out the thoracic pleura when you're in there doing the lung reduction? Would it be good or bad? A good or bad idea?
Yes, the air leak is a significant problem. What is the question?
Pleurectomy, thoracic pleurectomy. Do you think there's any advantage? Would it help prevent late onset spontaneous pneumothorax by promoting adhesions?
Pleurectomy?
Yes.
To do a product? We usually don't do it. We want to do the procedure as simple as possible, and I don't know if some group have really good experience with this, and also talc I would not use as a first line prophylactically.
But
so we use sometimes glues, if there are different glues, the Pleurazil or different glues when you have a lot of adhesions and you end up with some air leaks. This may help, or
if you have an air leak and you have a pleural space usually, and then pleurectomy doesn't help, because you don't have contact to the thoracic wall. You had to do a pleural tent, for these patients, or I think everybody's using buttressing and glues nowadays, and you have to wait. You don't have to put on too much suction and not expand the lung, force the lung to expand. I think this is much better strategy.
Yes, in spite of doing all this, but I did get the answer. Thank you.
Dagut?
Well, post-operative air leak is a common problem that we all deal with, but at least in my own experience, I can't recall a patient that has had a spontaneous pneumothorax after recovery from lung reduction surgery. We've done approximately 550 lung reduction operations in our center, and we may have had one, but I can't recall a late spontaneous pneumothorax. So I see it as only an acute issue of management of air leak, not a chronic issue of potential late pneumothorax, and we do not do pleurectomy.
We want to thank all the speakers for keeping to their time, and more importantly for the excellent presentation. Thank you. Thanks, Ralph.
We are coming back sometimes, I saw.
Yes, you are. Nice. No, where's the sheet? I can't find it. I'm sorry. Okay. Yep.